Hello, everyone. I was just saying to one of my colleagues that, many of the times that I'm presenting, it's in sort of a research conference context, and this is such a refreshing change to be in a room with people who are on the front lines practicing and seeing patients. So I'm hoping to be able to impart some of the experience that I've had in our research lab as well as our clinic. And I'll be sort of presenting for a little bit, and then I have my colleague Rickard Wicksell, who's going to be coming up and presenting as well. So I'm going to be talking about fear and chronic pain, mechanisms and effective treatment. And I have sort of two institutions on here. Boston Children's is where I previously was, and a lot of the work that I'll be presenting comes from that. And Stanford is where I am now. So if you need to find me, that's where I am, not so far away from here. And the weather is actually better right now in Stanford than it is here, which is crazy. Okay, so I imagine, so in the room, how many of you actually treat children or adolescents with pain? Oh, yay, that's many more than I anticipated. So just briefly, I wanted to talk about, for those of you who don't, that chronic pain is a big deal in kids. And this is actually something that comes up a lot when I meet people. They say, oh, I didn't even know that kids had chronic pain. In fact, it's a $20 billion problem in the US alone. And about a third of children suffer with chronic pain. And 3 to 5 are pretty debilitated by it. And when we think about chronic pain, as you all know, it's incredibly complex with the sort of interplay of physical, emotional, cognitive, and behavioral components. So importantly, children ultimately grow up to be adults, which I imagine everyone in the room knows. And this is important in considering pediatric chronic pain and that prognosis. So for example, recurrent abdominal pain is something that a number of folks go on into adulthood to have psychiatric comorbidities, functional abdominal pain or IBS as adults, and they have sort of pain sensitivity or things like temporal summation differences. So their ability to sort of modulate or interpret pain signaling changes based on that experience in pediatrics. Pediatric migraine, many people develop migraine in adolescence, and about 51% of them, in a study that was done over 40 years, 51% continued to have migraine symptoms in adulthood. And fibromyalgia, that's another condition that many people say, wow, I didn't realize that kids or adolescents have fibromyalgia. And there was a recent study done by Susmita Kashkarzak at Cincinnati Children's that showed 51% continue to have fibromyalgia in adulthood that were diagnosed in adolescence. And complex regional pain syndrome is another condition seen in children, and about a third of those continue to have those symptoms in adulthood. So when we think about pain systems and how we're going to target intervening, there are so many physiological as well as psychological systems at play that focus on things like your sleep-wake cycle, endocrine system. All of these things are disrupted in the context of chronic pain. As a psychologist, most of my work has focused on sort of the psychological systems, but they're all interconnected, and they all sort of feed forward into sort of your brain circuit networks and ultimately what we see in the clinic in those behaviors. And of course, in childhood, you're also dealing with development. So that sort of overlay of puberty, hormones, and all of those contexts that shift and in some ways make a child more sort of plastic in their nervous system, more resilient in the context of pain, but also complicates the picture when understanding what you're supposed to be targeting. So how does problematic fear develop? So as you can see this picture here, this is a well-intentioned mother who has a love for roller coasters, who wants to impart this in her 2 children. So we've got my 5-year-old here sitting next to me and my 7-year-old in the back. And this is in Santa Cruz, for any of you guys who are interested in checking it out. So we're going on this roller coaster ride. And you can see a little bit of sort of pensiveness in my 5-year-old sitting next to me, but he's willing to go. And this is during the roller coaster. And as you can see, I'm having a blast, and I'm clearly that sort of mom that's not paying attention to the fact that he's absolutely petrified. And I actually feel quite bad. It's like one of those roller coasters that you go around twice. And after we stopped the first time, the guy's like looking at my son, and he's like, do you guys want to get off? And I'm like, no, we're fine. And my 5-year-old burst into tears. And so, mind you, we did end up not going that second round. But I should show you later on that same day, he was perfectly recovered. But it's very easy to see how sort of fear can unfold and develop. And fear is so powerful that it can, happen in just one instance of an experience, or even sort of someone telling you about their experience. It's pretty powerful, and I think it, plays a big role when we think about pain persistence. So these are, some of the factors that, we sort of think about and are beginning to be studied in contextualizing how fear learning develops. So our attentional processes, how we appraise a situation. If we think that a particular situation is threatening or not. And then we have things like memory. So I can tell you it's going to be very difficult to get my 5-year-old on a roller coaster anytime soon because of that memory of that initial experience. Mind you, my 7-year-old looked terrified as well, but he had a blast. So it's all about sort of how you appraise the situation as well, right? So things like motivation and genetics. And your emotional state all kind of feed forward into this kind of fear learning process and ultimately your response. So I imagine many of you are familiar with Johan Vliet and some of the work that he's done with developing the fear avoidance model. And I think he came out with the first model in 1995. So we're looking at, 23 years later. He's most recently come out with sort of an updated version, and I really like it because I think it sort of highlights sort of where the field has evolved and some of the things that are really clearly important to think about when we think about how we're making these kind of threat appraisals and how we move towards either approaching a situation or continuing to avoid. So what has been sort of integrated into this newer model is this idea of the priority towards pain control versus focusing on valued life goals. And I'm going to sort of revisit that theme, and Rickard's going to talk more about that as well. But I think that's really critical in understanding how individuals make the decisions of whether they're willing to kind of be pushing towards that pain experience or moving towards that pain, or whether they continue to engage in kind of avoidance behavior. And, Dr. Vliet has sort of integrated a lot of the experimental work as well in thinking about kind of how does kind of a pain, we know that sort of we're hardwired to fear pain, but how does it become sort of a persistent response? So thinking about sort of that automatic tendency to avoid, and, how very quickly, very neutral experiences can have that same kind of threatening perception, or even the anticipation of that activity is going to cause me pain, so I'm going to avoid it, without ever even experiencing firsthand that bending over, elicits the back pain. And clearly that sort of generalizes very quickly, but the good news is that we can use exposure to begin to sort of extinguish the pain, or extinguish the fear. And I think what has come a long way in understanding extinction is that it's not an kind of eradication of a fear memory or an eradication of that fear, but rather it's new learning that's being sort of kind of taking place. So what does exposure for chronic pain look like? So I'm going to talk a little bit about what we've been doing in our pediatric setting. So it's a little bit different than the traditional pain-related fear exposure, in vivo exposure that Johan Vliet developed many years ago and has continued to refine. because we've had to make some adaptations to sort of take into account some of those things that I talked about regarding development. So I'd love to sort of talk more about this and sort of have a nice dialogue about, this particular intervention and how we've, modified it, and, if folks are doing this in their practice and how it's working or not working. I was just talking about that at lunch today, in fact. So the intervention that we sort of developed a few years ago, we called it Get Living, Graded Exposure Treatment. And it really sort of has those initial hallmarks of what the in vivo exposure has, which is, includes psychoeducation, developing a hierarchy, and then actually executing the exposures. And the way that we set up this intervention at Boston Children's, and we're now starting it up at Stanford, is it's delivered with a physical therapist and a psychologist together. It's on an individual treatment basis, and it consists of 12 sessions twice a week for 1 hour. And it includes the adolescent and the parent in the room. So for those of you who work with teens and kids, you know that having the parent engaged, having them involved is incredibly important for seeing the treatment that you want to have implemented, generalized at home, and getting buy-in from the whole family. So what we realized, the best way to do that is by actually having them in the room. So that's what we do. So initially, we start out with a really simple model of how sort of the cycle of avoidance unfolds. Thinking of a particular activity that, for example, a lot of our kids with CRPS, they're, fearful of maybe even, putting on their shoe. And, we sort of address the ideas of the worries, the anxieties and fears that come up, and how just sort of avoiding that particular event is very reinforcing, because there is that sort of sense of relief that comes with avoidance, and that sort of feeds back in. And we can all relate to that. I know I was like a lifelong procrastinator, and there was a lot of relief that kept me in that vicious cycle. So it's something that even outside the context of pain we can relate to. And when we think about sort of the bigger model, it gets pretty complicated when you're thinking about how this unfolds with the thoughts. Also, that my thoughts about pain is also labeled sort of catastrophizing, but using the word catastrophizing doesn't really isn't always resonate, or it needs its own definition. So, we try to sort of break this down into kind of more simple terms. Thinking about the worries, that's the pain-related fear, and then the activities that they're not doing and the avoidance. And then you overlay that, the sort of other elements of kind of the parent in that picture of how they sort of interpret their child's behaviors, their thoughts about the child engaging in particular activities, their responses, and how it impacts the entire family. So in the treatment, we sort of go through these elements, and we actually have them kind of develop and create their own worry cycle. So they sort of write down the thoughts that they're having, the worries they're having, and it's not a clear sort of, you have this thought, and then it leads to this worry, and then this to behavior. And a lot of times they're converging all at once. But we have them sort of begin to sort of disentangle some of these elements to understand where they got to where they are now, and how ultimately it's impacted their life. And then we talk about the path to Get Living. So how do we get out of this? So this is sort of what we put forth as a way of sort of conceptualizing what they need to do in order to break the cycle. So we talk about sort of, this is really almost in a frame related to sort of acceptance commitment therapy, values-based sort of understanding, without saying like, we just want you to accept that you're in pain. We talk about like acknowledging that the pain is here for now. And when we first started this treatment, it was just, it's okay that I have pain. And for a lot of kids, a lot of parents, it wasn't okay. They didn't like that idea, and they didn't accept the fact that that's what we wanted them to sort of be okay with in order to engage in the treatment. So we said, okay, well, how about for now? Because you're sort of in this sort of tension between what we're trying to deliver and what they're hearing in the physician's office. That sort of biomechanical or biomedical sort of orientation of, we're throwing this medication at you, we're gonna like fix the pain. And so we're working with that and trying to sort of sidestep that process that they're sort of still engaging in while trying to get them back to living their life. And so we move towards the acknowledging the pain, doing activities in the face of pain, and really sort of choosing values. So that's where we kind of move into creating these values-based goals. And this is directly from ACT and has really sort of been powerful for sort of what we do in the intervention is we've done the psychoeducation and then we do values exploration. So we have the child and the parent in the room talking about, what kind of sister do you want to be? What kind of friend do you want to be? I want to be a good listener. How does pain interfere with your ability to be a good listener? And they'll talk about, I find myself talking about my pain all the time or complaining about my pain, and I really, don't ask my friends how they're doing. And so it's kind of, some of that is like a mind shift of thinking about how they can relate to the people in their lives differently to be more consistent with their goals, which is ultimately going to change their kind of behavior day to day. So we go through and we set these goals, short-term and long-term, in the domain of friends, education, activities, social, family. And then we have the parents do it as well. So, how can they support their child in making their goals? So, and having them sort of wrestle with some of the concerns they have about having their child go to a sleepover when they feel safer having them at home, because if they have a pain attack at night, they're going to be, at home with that versus letting them take the risk of being out. And so once we've set those sort of goals in place, then we go through and work on the hierarchy, or what we call like the fear stepladder for the kids. And we developed this, so it was initially developed in adults, the FODA, photograph of daily activities, and then it was adapted for adolescents in Dutch, and then we translated it into English, and that was the most recent version. And this measure is one that we're like this close to being able to sort of have it available to different institutions. So it's all web-based, and we're setting up sort of the databases so that people can, administer the measure, get it scored, and then, be able to use it in clinical practice. And when we developed it and at Boston Children's, one of the things that we did that was kind of cool is that we actually tried to do sort of an intervention, assessment as intervention. So we had half the patients who completed the measure, and that was it. And then we had half the patients who completed the measure, and then they got a copy of the report. All of their providers, so the physical therapist, occupational therapist, psychologist, would get a copy of this report regarding what activities they were worried about doing, how they thought it would be harmful to their pain, how painful they thought the activity would be. And it would sort of begin a kind of dialogue regarding these activities. And, we didn't see huge, robust differences between the two groups. What we discovered is that changing sort of clinician practice without a lot of coaching has its own set of challenges. So it was hard to actually get the clinicians to use it. And when they did, the kids gave us the feedback that they really thought it was great. But overall, one of the cool findings was that almost all the kids actually said it was helpful to complete the measure. And I do a lot of assessment research. And usually kids are not excited about filling out questionnaires. So the fact that they actually enjoyed this was really helpful. And I think they learned something about themselves and the things that they were kind of struggling with getting back to. So this is an example of an activity stepladder. And this was a kid that we had in the program that was really sort of, she wasn't one that could sort of sit still. So instead of like we had like the activities that she had described as difficult for her, and then we'd have her like tape them on the board to get her more engaged with the activity. And then we proceed with the actual exposures. With the sort of main principle of, the more you do it, the easier it gets. This is something that came out over time in our development of the exposure protocol, which is, based on sort of traditional exposure. We would ask them to give us a SUDS rating, or subjective unit of distress. From 0 to 10, where are you at right now before you're about to do this exposure? And what we discovered is that a lot of the kids really struggled with thinking about it outside of their pain. So they would say, well, I'm like an 8. And then we do the activity, and they do it beautifully, and they say, well, now I'm a 9. We're like, well, wait, how did that happen? And what we realized is that really they were thinking about their pain experience because they were so used to reporting the numerical ratings of pain that disentangling their kind of worry, anticipation from pain was very difficult. So we came up with the WILD scale. And this really sort of, again, pulls from that sort of kind of acceptance and commitment, sort of value-based sort of orientation. So we asked them to rate, how willing they are to do the activity, if it's important to them. And this one is, it's kind of funny to include it because we don't actually, if they say it's not important, we say, well, let's not do it then. Let's pick something that is important to you. So that's almost like an eliminator of the actual activity. How successful do you think that you'll be? And then how difficult do you think it will be? And then we have them rate at the beginning of the session and at the end of the session. And this is allowing them to move away from that sort of numerical rating and also sort of think about it a little bit different and get them sort of primed to think about that sort of shift in their sort of thinking about it. Another thing that we learned from experience is that a lot of these kids and parents had been sort of trained to be told, like, well, what are my coping skills? What is my toolbox? What am I supposed to be doing? So what we came up with were thinking about strategies that we felt were consistent with keeping them engaged in the exposure without, so we didn't want to do things like distraction, because we didn't want them to not recognize what they were doing or that how far they were progressing. So we talk about things like activity facilitators. So one of my favorites is actually listening to music. So I say, like, I don't run without listening to music unless I'm with someone else. They're my music. But it's, it's maybe considered a distraction, but in fact it's something that facilitates my engagement in the activity. And so we talk about, figuring out what their sort of exposure action plan will be as well. And this is sort of a brief example of what this looks like in action.
And you cleared it the first time. What do you think you need to do to keep clearing it?
So this is a PT who's sort of running the show in our exposures.
Go ahead, we'll lower this one. So you tell us what's a good height.
That's good.
Okay, we'll stop right here. Nice. Oh, land on the mat. That's okay.
Very
You
nice.
fell and you landed.
Okay.
And how many times do you fall in gymnastics?
Maybe a few.
I fall in my everyday life. so you fall in gymnastics, probably not too bad,
Not
right?
too bad. Yeah.
Okay. Do you think we should stay at this height?
Yeah.
Okay. You want to do it again? If we do this over and over again, what's going to happen?
I'll get used to it.
Yeah. That's okay.
I'm scared.
And what else can happen after you do something over and over? Can you sometimes get a little tired? Yeah, so when we're doing this, we can't do this like 800 times, right? Because if you did that, your legs would get tired and you're simply not going to clear it, right?
You might just crawl under at that point, right?
So that's why it's important to do things like take breaks.
So what might you do for a break? Well, I guess the first question is, are you tired right now?
No.
No, you're okay?
You just said something pretty smart.
What?
What did you say?
Water.
Yeah.
That sounds good to me. Where's your water?
I drank it all.
You drank it all. We have some water right over here. Water refill.
Of course, she had to go for
That's
her mom's
Mom's water.
That's not your bottle, though.
No, someone gave it to me at work because I forgot it at home, and they didn't want me to get dehydrated.
I should go back over so I don't bring it with me.
And what are some other things we might want to think about when your legs are tired after jumping like, I don't know, 40 million times? What else could you do to take a break before you get back into it?
Take deep breaths.
Take deep breaths, that sounds good.
Walk around if you can.
Bingo.
That's what I do.
Yeah, that might help. I think you might do that a lot in gymnastics,
Yeah.
right? Yeah.
Like when we're doing tumbling, I might like walk a little bit before I
Yeah.
do tumbling again.
Yeah. And that makes sense, right? Because your muscles get really, really tired, right? And they just learned this like new height. This raised height, right? This new activity, this new challenge. And your muscles are saying, hey, I just need a quick break, a quick breather. But I think I'd be ready to try it again, right? When your muscles are learning something, you're learning something, right? Awesome. So you let us know when you're ready. You ready? Okay. So there you go.
On the way back.
Is this a good height? I think it's the last height we stopped at.
It's high.
It's high? It's the same height as last time.
It is.
Mm-hmm.
It's like I feel more like secure when there's like more gymnastics when there's a big block. I don't worry that much.
Yeah.
I don't fall or off or something like that.
Yeah.
So you know what that means? That this is actually probably really great because when you've conquered this, when you go back to do those blocks that you feel more comfortable with, you can think about this experience and go, you know, I jumped over that rope
With these two crazy people.
Yeah. And I didn't have all those other supports in place, so this
Yeah.
is going to be a breeze.
Okay, I'm ready.
All right.
That was not the same height.
Was it higher?
Yeah.
Yeah.
All right. It was the same height, but you know, whatever. So just briefly, these are some of our brief outcomes. So we, you know, where we saw the largest effects were things like sport activities, which, you know, are going to be sort of the most physically challenging, which is fantastic. And, you know, in this we have a number of things that we're looking at, and you can see sort of two things going up, and that's sort of activity engagement and pain willingness. And, you know, our fear, avoidance, and disability are all going down, with sort of pain not making big changes, but that's not what is critical. But often it isn't simply fear, so that is where I'm going to introduce my colleague and let him sort of talk a little bit about behavioral flexibility.
Yeah, Laura will be coming back, so don't worry. I'm an associate professor at Karolinska Institutet in Stockholm and the director of medical psychology at the Karolinska University Hospital, which is in Sweden, the home of IKEA, the Nobel Prize, and Pippi Longstocking. Laura and I, we share the interest in the exposure-based treatment because that's essentially what we consider to be the most potent psychological intervention. If we can effectively provide that type of intervention to individuals that suffer from chronic pain, there is a great likelihood that they will increase their ability to live a vital life. But the consequence of the effects of that treatment can sort of vary. And Laura's talked about like the fear avoidance model, and it kind of emphasizes fear, but it could be more than fear. It could be, the avoidance behavior could be related to other processes. So essentially what we want to do is to help individuals to change their behavior pattern. And that's really a decision process, and it's a difficult one. So I'm going to talk about exposure from an ACT perspective. Acceptance and commitment therapy is developed as sort of within the CBT paradigm, and it's based on exposure. It's sort of a dancing around exposure. But exposure can be done for different reasons. So I'm going to talk a little bit about that. How many of you in here has some sort of experience or knowledge about the acceptance and commitment therapy model? So yeah, it's not totally unknown. And I sometimes use this picture sort of to just conceptualize what ACT is about. It's not very likely that someone starts out with chronic pain. It happens. And it normally happens in someone's life when they are in a situation where they have like a wide, broad behavior repertoire and hopefully quite a meaningful life. They're doing a lot of interesting stuff. But when pain sort of gets into the picture, people develop a sort of a tendency to avoid the risk situations. And that's not very hard to understand. I think that we all can figure out that it's like we don't put the hand on the stub twice, do we? It's hurt, and then should we try it again? No, we don't do that. And the same thing for people with chronic pain. So they have a tendency to develop some like a careful attitude towards the risk situations. And that is obviously effective when it has to do with like acute pain. But most often that type of carefulness becomes difficult because it works short term. The level of distress or the level of pain is minimized. So in the short term, it's great. But over time, that type of behavior pattern, because it is positively and negatively reinforced, becomes sort of a vicious circle that tends to be sort of a downward spiral. So if you ask a patient with chronic pain what life was like 4 years ago, for example, they normally describe that they did more than they do now. So we can all understand, I think, intellectually why individuals get into this downward spiral. I think, can we do that? Do we understand that? It's not very complicated. Like, we become more and more concerned with things that are like associated with pain. So many people then find themselves ending up very like in the spiral, living a very limited life, but paradoxically with the same level of pain. So from an ACT perspective, what we want to do is essentially to help the individuals move upwards in the spiral. And that makes sense, but it's difficult because we cannot really have the objective of reducing pain by doing more of the things that are associated with pain, can we? So the rationale for the exposure-based treatment is essentially to increase the behavior repertoire in order to increase the level of functioning, to get a meaningful life rather than less pain. So when we talk about this, behavioral flexibility is our core construct, the treatment objective that we kind of try to get at rather than reductions in pain, reductions in distress. And what do we mean by behavioral flexibility? Well, the definition of it is essentially to increase the ability to act effectively in alignment with your life values, also in the presence of pain and distress. And what is that? Well, it's a behavior. It's something that you do, but it's a complex behavior, or it's composed of different type of behaviors. So within behavioral flexibility, we see things happening that could be labeled noticing, accepting, redirecting attention towards values, choosing, executing, or like taking actions in a valid directions. All of these are sort of subcomponents of behavioral flexibility. So throughout these 15 years, we've been trying to develop this model. We've seen that behavioral flexibility really is a key component or a key change process. So essentially, if we can increase behavioral flexibility, people can start to get upwards in the spiral, also in the presence of the pain that we as physicians, PTs, psychologists cannot remove. So ACT is more about helping the individual to take control of their life by accepting the things that is very, very difficult to change. So ACT sometimes is described as sort of a model where we combine change strategies, behavior change strategies with acceptance strategies. So I think you can all see where acceptance comes into play here. In order to increase functioning, you need to do the things that you have been avoiding for quite a while. And to do that, you need to decide to actually accept the things that occur when you do this. More than anything, I think we're talking about a decision process. We kind of know what the individuals should do in order to get a better life. But the problem is we need to make them do it. And that's, I think, the sort of the enigma, how to make them get to the point where they actively choose to do that. So what we are doing, as Laura said, we are trying to talk about the things that makes it worth it to go upwards in the spiral. So ACT and this type of exposure-based treatment that Laura is involved in as well really has to do with like existential questions. Like what should life be? Who do I want to be in this life? What's truly important to me? But a functional definition of behavioral flexibility essentially is about what do I have to do to get upwards in the spiral, or in order to live a life that is active and meaningful or vital. And that could be something that I continue to do in the presence of pain, or something that I change in order to get more of the things that I value. So compared to traditional CBT, ACT can be described as something that is focused on exposure, but with a slightly different objective. So functionally, the exposure is aimed at something slightly different than symptom reduction or like distress reduction. So the exposure is sort of the key feature, but it's aimed at increasing the behavioral flexibility. So we thought that it might be interesting to, well, we are psychologists, so we thought we should do an exercise. We might get into something that has to do with sharing early memories and shit, but I think you know each other well enough by now. So, well, we're not going to do that. But if you like could pair up so that you're like, find someone that you can do this exercise with, and then I'll tell you the rest. So just do that in 3 seconds. So in order to make this a fast process, the one closest to the window is going to be the experimenter, okay? And the other one is going to be the subject. So this whole exercise has to do with behavioral flexibility and sort of the core features of it. So we essentially want you to just experience what we mean by behavioral flexibility. So the subject, the one to the right from me, roll up your sleeves, or it's fine with one. So essentially you do this. And the assignment is really simple. You do this, and then you're about to focus on 2 things. The physical sensation, and if it occurs, any urge to act. Okay? 2 things. The physical sensation and the urge to act, right? So the experimenter, the one to the left from here, wait for the written instructions. So the subject, please close your eyes. And it's very good to be an ACT therapist, because if you're like reluctant to do this, I will ask you, are you willing to? And then you have to do it. All right, okay. Have you closed your eyes? Promise? So, the experimenter. Read that slide. So the subject, remember, notice any physical sensation and notice any urge to act. Well done. Yeah. So in the hopes you're not traumatized, please open your eyes. Yeah, well done. Yeah, and feel free to just continue to do this tonight with someone. So, so just wrapping this up. So the behavioral flexibility really is about being able to notice the physical sensation and the urge to react in order to provide the individual with an ability to choose to act or choose not to act. Because many times the behavior will be counterproductive. It will lead downwards in the spiral. And in order to change the behavior pattern to, in the same situation, behave in a way that leads upwards in the spiral, you need to be aware of the physical sensation and aware of your ability to actually choose the behavior. So this, in essence, is what we're trying to teach the patients through instructions, but also through exposure type of exercises. So yeah, well, I guess that was it. And well, yeah, right. I have one slide. Sorry.
What was the idea
Of the exercise?
of that? We know it's going to do something, so that's why I don't react. I mean, what was the point here? You get the point.
Oh, sorry, you didn't get the point. Well, the point is that we want the spiral. What happens for many individuals is that you get into a behavior pattern that is characterized by avoidance. And it's very intuitive. If it hurts, you stay away from it. In order to change that behavior pattern, you need to be able to notice the fact that it hurts and then stop for a second and figure out in what direction do I want to go. Because I can't stay away out from the pain. But that will likely lead me further down in the spiral. So the type of behavior pattern that we see in individuals with chronic pain is many times like a behavior pattern that they are not aware of themselves. It has become sort of the normal way of dealing with life. You stay away from things that are associated with pain. So we try to teach them to notice what's happening in order to increase the control over the overt behaviors. So that was sort of the exercise. Yeah, good. And we did this with patients that had different types of pain. And I show you this because I think it's quite interesting. Sometimes we get the questions from reviewers saying that, okay, you increase functioning, but maybe that's because pain decreased. So we wanted to look to see if it's actually possible to increase functioning in the presence of pain. And so this is a single subject design study where we measure pain intensity and valued activities. And this is one patient. And as you can see here, nothing really happens with pain. This is sort of the assessment phase, the education phase, and the exposure phase. Nothing really happens with pain, but there is an increase in the level of valued activity. And the same thing with this activity. Here is another patient, and the same pattern. Nothing happens with pain, but there's an increase in the activities that the subject considered to be important in life. So this is essentially a proof of concept. This is, from an empirical standpoint, what we mean by behavioral flexibility. Right, so back to Laura.
Oh, no, I'm done.
All right, she's done. You want to just finish it up?
Yeah, so if you want to hear about this stuff, I can talk to you offline about it because we don't have time.
All right, okay.
We do have about 15 minutes for a Q&A, so and let's have both of you up here.
Sure.
So that You can direct your questions at whoever you like, or either one. Why don't I have you come over here? And then I'll just stand out off to the side. And we've got our first question on this nice tall hand here. We've got a microphone coming up right behind you there, Jeff.
How does this affect brain plasticity?
Okay, while we're doing Q&A, someone else can ask a question. I can quickly show you a slide. So my other sort of hat is I do a lot of brain imaging research. Yeah, I know you have Vanya Apkarian coming tomorrow. He will really dive deep into this. But we essentially were able to show that changes in sort of treatment response and brain circuitry was associated with decreases in pain-related fear. So my sort of interest is like, how do we make these sort of brain changes like meaningful in sort of clinically important? And so tying sort of processes that we understand, like, you know, fear and brain function. So that's as far as I'll go with that, but anyway.
All right, and then we have a couple of questions over here on the right. We've got two side by side and then one up here.
Okay, thanks both. I thought it was a wonderful talk. Thanks very much. I'm interested to know your thoughts on the thing that we often see within practice is the word acceptance. And obviously patients sometimes will give a bit of pushback and say, does this mean I just give up? So I was wondering on your thoughts as to how we might reconceptualize acceptance.
Sure. Well, yeah, I don't think that I've, in 50 years, used the word acceptance with any patient.
Yeah.
Well, I probably have, but it crashed and burned, so I just erased it from my memories.
Got it.
Sometimes we use pain willingness sort of as a term. I don't find it necessary to do that.
No.
What I find to be relevant is to address the behaviors and sort of the reason why they're doing it. I mean, if I send the child, or actually the adult, home with sort of an exercise to explore something that has to do with getting towards a more meaningful life, and they come back and they have hopefully done something, I ask them, what did you do? And they tell me that they did something. And then I say, okay, so I'm not going to ask you if it was painful. I'm not going to ask you if you were scared. I'm not going to ask you if you blah, 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 because I know that,
right.
Of course. But I'm going to ask you one thing that I don't know. Was it worth it?
So focus on the solution, not the problem. Yeah.
Yeah, I mean, like, acceptance is sort of, it's within the exposure.
Yeah.
So you can talk about where you want to go, and you can talk about where you end up if you do the things that are sort of intuitive. So yes, we want to do something that is counterintuitive, but we need to identify why, what, and how. And we can talk about that without making it complicated with terms such as acceptance.
Sure. Thank you.
And right next to Mike, Sharna.
So, Laura, you said that you treat your patients with the PT and the psychologist, one patient and the two providers. Do you guys ever do group settings? And if not, why?
So in the program that we've been running, we haven't done it in a group-based intervention, but Susmita Kashikarzuk at Cincinnati Children's has a program called Fit Teens for youth with fibromyalgia, and she does something. It's not with physios; it's with like trainers. I'm blanking on the sort of technical name, but essentially they do like a group-based intervention. So I think I think there's multiple ways to get to the problem. So I think it is possible to do it in a group-based format. I think what is nice about the individual is that you are really harnessing and focusing on their particular values, their particular activities, and building the exposures around that. So it's like, you know, an individual PT session, and all of those exposures are sort of done by the PT. And what I didn't mention is that half of the time the parent is observing those sessions, and half of the time the parent is meeting with the psychologist to get sort of coaching and around sort of how to sort of shift things at home, as well as their own sort of distress and distress tolerance related to seeing their kid in pain and encouraging them to do more.
We have a question right up here in front, Lysanthia. While the microphone's on the way, could you expand just a little bit on the importance of the parent education piece of that program?
Yeah, for sure. So, I mean, it's really interesting. When I first got into pain treatment, there was a lot of talk about what they would call like a parentectomy. So let's remove the parent from the situation, fix the kid, because it's clearly the parent's fault, and then we'll send them home and they'll be great. Well, the problem is it's not the parent's fault. It's just like all of this. It's that sort of a parent's response to their child in pain and suffering is to nurture them and to care for them. And so they're doing what they know. They're doing that natural response, just like, we're trained to respond to pain in a certain way. So essentially, by removing the parent, we're also isolating them from the important education of how to relate to their child in the context of pain and how to encourage them to sort of kind of expand their repertoire of responses. So we really sort of have shifted a lot over time. And so now there's less of that emphasis on kind of removing the parent's influence, but rather sort of trying to join with the parent as much as possible throughout the treatment so that they are sort of completely engaged. And even in sort of my outpatient pain treatment, I often, when I'm introducing a new technique or strategy with the patient, I'll have the parent in the room as well, because if there's any sort of sense of like, I don't know what's going on when you're in that session, and the kid's not necessarily like volunteering a lot of information, we want the parent to sort of really feel like they know what's going on, that they understand the treatment rationale, the process, and can sort of support those changes at home.
Thank you. Question right up front here, and then another one in the second row.
I'm going to come back to the concept of acceptance. So my question kind of got already asked, but with that, even the word, and I love that you say that, like, don't use acceptance because it's so badly responded to. Like so many of the other concepts that we talk about in the room here, and we sort of then have to find another way to talk to patients about that, like the pain is in your brain thing that we really don't want to broach that subject. I wondered with those patients have you studied or have you explored how those patients feel about the fact that maybe they do get their life back, but the pain is still there and the pain doesn't change. And a lot of the things that comments that patients and people say in their narratives is, if this pain would just go away, all of that other psychological stuff wouldn't be there. I wouldn't have to think about it. And while we know lots of different things feed into that, are we studying this? How do we understand that experience?
Yeah, well, I think it's a good question. What we see is that it is possible for patients to do things that are vital to them, also in the presence of pain. I think that's an important message. From a clinical perspective, I've numerous times seen how people are expanding their behavior repertoire. They're doing more things in the presence of pain. So they are liberated in a way. But what happens is also that the relationship with pain changes. So sometimes people articulate that in certain ways. And one of the things that I've heard is like, I'm not afraid of the pain anymore. I'm not sure it's exactly the same as fear of pain, but they say like, it doesn't scare me. So I think that's quite interesting. And another thing that I find to be very, I've been working with a pediatric anesthesiologist forever, and it was funny because he couldn't resist from asking, like after a treatment that we thought was quite successful. So he was like curious. So what about the pain? I was like, oh, damn, don't, please, come on. We've spent like 10 weeks trying not to sort of get into that stuff. But she was a teenager, and she said, well, funny you ask. Of course it's there. It's the same, you stupid. That's not the thing. I'm living, the best life I could ever, dream of. So yes, pain is there, but it doesn't stop me from doing what I want to do. So I think that sort of illustrates sort of what we try to accomplish. It's not about reducing pain or distress, really. But if that happens, well, I don't mind. But it can never be the treatment objective, because you can't control it. It's not something that you choose. You can choose your behaviors. You cannot choose your experiences.
And Joan here, this might be our last question.
Hi. So I've been working with adults with chronic pain for about 24 years, and obviously there's an increase over that period of time in the numbers that are suffering from that. And I have some ideas about the biopsychosocial factors that have contributed to the increase in chronic pain. And I was surprised. I didn't know 51% of pediatric chronic pain. And I just wondered if you were willing to share some of your ideas about what the biopsychosocial factors may be for that population.
Oh, yeah. In the sort of transition from pediatric to adult chronic pain?
Or if they're even, or are they different? Are they different, not in the transition, but the factors?
In the sort of contributing factors between the two? Probably not so different.
Yeah.
I think that there's, social, just like the biopsychosocial model sort of indicates that there are social determinants, there are sort of vulnerabilities, that all sort of feed into it. I don't know that there's anything particularly unique about the child. I know we're probably doing a slightly better job of understanding sort of the interactional patterns between child and parent and how that sort of promotes function or promotes sort of the vicious cycle of disability and pain-related avoidance. I don't know that there is as much of a rich literature regarding things like partners and family members in their role in that sort of social determinants of pain persistence and disability. So, yeah, I don't know if that sort of gets at what you're...
Have there been any social changes over time that...
Like societal?
Yeah.
Well, there's like that thing, the opioid epidemic, that's sort of been an issue that certainly has sort of changed the narrative about how we think about pain rather than it being sort of lived experience that we all at some point experience pain, but rather pain is something that should not be tolerated, it should be eliminated. So I think there's been a cultural shift in that sort of fix-it mentality that I think probably plays a big role.
Thanks.
That was the